I'm an associated professor of hematology. You see my curriculum of vitae. I have been graduated from Hacettepe University, and then I have finished my internal medicine clinical residency and hematology fellowship in Dokuzeli University, Izmir, Turkey. And while I was in my fellowship, I have visited Mayo Clinic, Rochester, in order to be educated among the plasma cell dyscrasias that we will talk about in details in this presentation. And then I joined to Medipol Istanbul University, and till February 2018, I'm a member of Medipol Istanbul University. And also I'm serving as the head of multiple myeloma scientific subcommittee of Turkish Society of Hematology. My main interests are plasma cell dyscrasias and stem cell transplantation and other cellular therapies. Using my academic workload, and I have been a mentee of Professor Shaji Kumar from Mayo Clinic, who is a pioneer in the field of multiple myeloma. So first of all, I will just briefly comment on the disease and what we are doing about this disease and what we have opportunities to present to our patients who are diagnosed with multiple myeloma. Multiple myeloma is listed below a title called plasma cell dyscrasias. These plasma cell dyscrasias is the malignant disorder of plasma cells, which are terminally differentiated to secrete immunoglobulins in order to fight with any kind of stranger object or any kind of tumoral tissue that grows up in our body. And in plasma cell dyscrasias, unfortunately, one of a kind of this plasma cells grows rapidly and multiplies in a huge fashion. And because of this multiplication, they secrete an enormous amount of monoclonal proteins, which can potentially distract and disturb some organ functions. As you can see here, in a normal person, we have a lot of different antibodies produced via these plasma cells, but in multiple myeloma, unfortunately, we have a clone of cells which are producing abnormal antibodies. We generally call these abnormal antibody as a paraprotein or a monoclonal protein. And this monoclonal protein is responsible of this tissue damage, which we can just see in this multiple myeloma. And the most common plasma cell dyscrasia is multiple myeloma. Multiple myeloma is the second most common hematological malignant disorder. In hematology, we have some benign disorders and we have some malignant disorders. These malignant disorders are called as neoplasias. And when we check the incidence of these diseases, lymphomas are the leading one, and the multiple myeloma is the second most common hematological malignancy. That's why this is an important topic. And I will just briefly talk about this disease specifically, which is called as multiple myeloma. If we check the history of plasma cell dyscrasias, first, Dr. Jones has defined this abnormal monoclonal protein. And that's why we call this protein in the urine of the patients who are diagnosed with multiple myeloma as Henry-Benz-Jones protein. But after decades, scientists further defined this abnormal protein in the urine as the light chain composition of abnormally produced monoclonal immunoglobulins, but still we call this protein in urine as Benz-Jones protein. As the advent of modern electrophoretic tests, scientists have managed to detect this abnormal protein in the serum of patients and termed this large abnormal protein on serum protein electrophoresis as M-spike. This opened a new era in the field of multiple myeloma. And as an advent of these techniques, nowadays we can just identify, even name the abnormal protein which is produced via these clonally expanding malignant plasma cells. Like in this example, we call this patient as having an IgG lambda monoclonal protein. Even we can just measure the amount of this monoclonal protein, which led to a new era, and I will talk about that briefly. But I just want to mention what happens if you do not diagnose or if you do not treat multiple myeloma in a good way. You end up with the fractures of bones, and you end up with renal failure, and you end up with hypercalcemia and a normochromic normocytic anemia. Like in this picture, this patient was the first in history who was diagnosed with multiple myeloma. If you do not manage to cure these patients, you end up with these bony fractures. Because in this disease, I will talk about the pathogenetic mechanisms, you end up with lytic lesions and osteoporosis and fractures in even long bones and even any kind of bones in the body. That's why we need to rapidly diagnose, and if the patient needs a proper treatment, we need to initiate that in a good fashion and in a good manner. This guy, called Robert Kyle, has defined some premalignant conditions in multiple myeloma, like monoclonal gammopathy of undetermined significance and also smoldering multiple myeloma. Actually, multiple myeloma is the first disease in the history which shown to be evolving from some premalignant conditions. That's why nowadays we can just check some patients who has a suspicion of M protein, and then we can just diagnose this disease before damaging tissues, before damaging end organs. That's why we need to be familiar with these terms, which one is monoclonal gammopathy of undetermined significance, and the other is smoldering multiple myeloma. If we can just diagnose a patient in this stage, which is not evolved to real multiple myeloma, we have the opportunity to turn back the process, and we have the opportunity to save the patient from the adverse effects of this disease called multiple myeloma. We owe this guy who has defined these entities. That's why we have some certain diagnostic criteria of these premalignant gammopathies and multiple myeloma. That's why we need to check some even healthy patients who has some clues that drives us to think about a possible monoclonal gammopathy. And when we check these patients, if we have a monoclonal protein less than 3 grams per deciliter, and if we have less than 10% of those malignant plasma cells in the bone marrow, and if we lack any end organ damage, then we call these patients as having monoclonal gammopathy of undetermined significance. If a patient has a more aggressive disorder, but even lacks these end organ damage, then we call these patients as having smoldering multiple myeloma. And you see the criteria, the diagnostic criteria of smoldering multiple myeloma. In this entity, we need an M protein over 3 grams per deciliter or a urine M protein of over 500 milligrams per 24 hours. And also in this entity, we have a higher plasma cell content in bone marrow. The clonal plasma cells in bone marrow is between 10% to 60%. But again, I underline that in this situation, we lack any kind of end organ damage. Multiple myeloma is a dangerous disease regarding bones, bone marrow, and kidney. If we have a hypercalcemia because of osteoporosis or the lytic lesions in the bones, and if we have renal insufficiency because of the overproduced monoclonal proteins, And if we have any kind of anemia in which hemoglobin level is measured below 10 grams per deciliter, and if we have even just one lytic lesion on skeletal radiography or computerized tomography or PET scan, then we call these patients as having multiple myeloma. This is paramountly important because we try to catch the patients before progressing or before evolving to this entity. And in my center, we have some clinical trials that we can offer to patients who are readily diagnosed with smoldering myeloma in order to prevent them from this evolution into multiple myeloma, in which we have these unwanted tissue damage, unwanted organ damage. That's why we are trying to catch the patients or trying to diagnose the patients before this entity. What about the morphology? The morphology is just like this. We have these cells. We can just show these cells clonally expanding in the bone marrow. That's why we need to apply a bone marrow biopsy in patients who we are in a suspicion for a plasma cell dyscrasia or for multiple myeloma. That's why we always try to proceed with bone marrow biopsy, and we try to show the presence of these abnormal plasma cells. This is the first step in order to obtain a proper diagnosis. You see those cells, these cells are called as plasma cells, and we can just count these in light microscope, under light microscope. And if these are over 10% of all bone marrow cells, we just be curious about a multiple myeloma. And if our patient harbors any kind of aforementioned organ damage, then we call this patient as having multiple myeloma. And we need to treat these patients in an efficient way in order to prolong their life expectancy and survival. What about the epidemiology of multiple myeloma and the premalignant gammopathies? The prevalence of monoclonal gammopathy of undetermined significance is 3.2%. It means if you just randomly select 100 healthy person, and if you apply a serum protein electrophoresis or immunofixation electrophoresis, or if you check for the serum free kappa and light chain, then you can end up with 3 patients having MGUS. That's why we are trying to incorporate some screening policies regarding patients who are in a high risk of multiple myeloma or in a high risk of plasma cell dyscrasias. And we know that this entity is more common in elderly population and also Black race. When we just check for the multiple myeloma regarding the incidence of multiple myeloma, when we talk about the incidence of multiple myeloma, as I previously mentioned, this is the second most common hematological malignancy after lymphomas. Again, that means this is more abundant than leukemias. It accounts for 1% of all cancers, and it's the 10th most common of all cancers, like prostate cancer, colonic cancer, breast cancer. When we just list down the commonest cancers, this is the 10th of them. And again, it's the second most common hematological malignancy. That's why we need to properly diagnose and we need to properly treat the patients who are presenting with this disorder. And its incidence is 5 over 100,000. It means you will add 5 new myeloma patients for 100,000 population in every year. You can just calculate newly diagnosed yearly myeloma patients, just multiplying this number with your population. And the median age of patients at diagnosis is approximately 66 to 70 years. Again, I just want to mention that this is a disease of elderly population. But again, we have some patients who are diagnosed before the age of 65 years. Around 40% of patients are diagnosed younger than 65 years of age, but it's extremely rare in those less than 30 years of age, with a reported frequency of 0.02% to 0.3%. And multiple myeloma occurs slightly more frequently in men, but it's just a ratio around 1.2 to 1. Why this is an important entity? Because before 1 or 2 decades, we could not be able to prolong the survival of multiple myeloma patients over 2 or 3 years. Unfortunately, we were just using some conventional chemotherapies, corticosteroids, and some other drugs in order to try to suppress the clonal plasma cells, but we were not able to prolong the survival over 2 or 3 years. But with the advent of some novel drugs that I will just mention about them, nowadays we can manage to have a 5-year survival rate of at least 50%. And also in some centers which is experienced in the treatment of multiple myeloma, we can now offer an overall survival over 7 to 10 years. That means we have just tripled or quadrupled the life expectancy with the help of some novel drugs. That's why we need to diagnose this disease in a proper fashion. What about the pathophysiology of multiple myeloma? I will not just go into details of these, but I just want to mention that in this disorder, we have some clonally expanded plasma cells, which secretes a lot of different cytokines and also immunoglobulins. And because of these cytokines, the bones are destroyed via the activation of these cells called osteoclasts, and also via the accumulation of the light chains of this overly produced M proteins, we end up with renal failure. And if we do not rapidly treat these patients, or if we could not manage to properly suppress this clone and suppress this overly produced monoclonal protein, we can end up with a chronic renal failure, and we can end up with an endless hemodialysis. But again, I just want to underline that with the help of some modern therapies, we are able to reverse this process, and we are able to have a dialysis-free survival, to offer a dialysis-free survival to our patients. That's why we need to be curious, we need to rapidly and properly diagnose and treat this disorder. This is the bone disease. As I told you before, in this disorder, these cells secrete some cytokines, which induces bone lysis. As you see here, this is a patient who is diagnosed with multiple myeloma, who suffers from lytic lesions on the scalp. And you see a patient who suffers from a lytic lesion on the humerus, on the upper extremity. Even checking for blood pressure can induce pathological fractures in these patients. That's why we need to properly treat, and we need to properly prevent these fractures, because these fractures sometimes causes lethal issues. We sometimes lose our patients because of this complication. How can these patients present in our clinic and which clues can help us to diagnose these patients, we should think for a possible diagnosis of myeloma in especially elderly patients who present with a new onset bony pain. This bony pain is mainly localized to back and pelvic region. And if we have a patient who presents with a newly onset pathological fracture, or if we have a patient who presents with a newly onset or worsening renal failure, or if we have a patient who presents with an unexplained normocytic normochromic anemia, especially if this is associated with a rular formation on peripheral blood smear, or if we have a patient who presents with an unexplained hypercalcemia, or if we have a patient who presents with an unexplained increased levels of erythrocyte sedimentation rate, then we need to check for a presence of multiple myeloma. We need to order some tests in order to show if this patient harbors this monoclonal protein, or if this patient has plasma cell increase, or if this patient has clonal plasma cell expansion in the bone marrow. That's why we need to proceed with bone marrow aspiration and biopsy, and also some biochemical tests to quantify and show the presence of monoclonal proteins. What about the prognosis in multiple myeloma? The prognosis is detected by some prognostic scoring system which incorporates serum albumin level. If the albumin is less, then the prognosis is worse, unfortunately. And also we check for serum beta 2 microglobulin at the time of diagnosis. If it's over a threshold, if it's more than normal, then this is correlated with a worse prognosis. This is associated with a worse prognosis. And if we have an increased LDH level in the serum, this is also related with a worse prognosis. But the most important entity which defines the prognosis is cytogenetic abnormalities. That's why we should order and test patients among these cytogenetic abnormalities at the time of diagnosis. If we have these translocations, then the outcome is poor. If we have trisomies, then the outcome is good. But with the help of some modern drugs, we can overcome the worst prognostic effects of these translocations. And some deletions and amplifications are also related with a worse prognosis. This is an important issue. Unfortunately, in some countries, on which there lacks a well-established expertise centers among this disorder, we have patients who are not tested among these cytogenetic abnormalities. Unfortunately, in that scenario, we cannot offer the best to those patients. That's why every patient should be referred to an expertise center regarding multiple myeloma in order to be tested for these genetic abnormalities, even some molecular genetic abnormalities. And then I can just comment on some other plasma cell dyscrasias like plasmacytomas. Plasmacytomas are plasma cell proliferation outside the bone marrow. If you have a plasma cell proliferation outside the bone marrow, and if you lack those plasma cells in the bone marrow, we call this entity as pure solitary plasmacytomas. And these pure solitary plasmacytomas can be cured by just radiotherapy, despite of multiple myeloma patients who harbors with plasmacytomas or multiple plasmacytomas. Why I have just mentioned this, that I just want you to know we have some tiny amount of patients who can just be cured via the help of radiotherapy. But besides of this fact, every patient who has multiple myeloma not solitary plasmacytoma, should proceed with a combination of novel drugs, not radiotherapy. We offer this to only the patients who are diagnosed with pure solitary plasmacytomas. These are some examples to this entity. This patient has this mass over this area. When you biopsy this mass, you end up with plasma cell expansion. But when you check the bone marrow of this particular patient, you lack plasma cells in that bone marrow sample. Then you can just, if you have no other masses besides this, you can just irradiate this area and you can achieve a cure in these patients. But the must and obligation of this approach is to be this lesion to be the only one, no other lesions, and also you lack plasma cells in the bone marrow. And also we have some rare entities, rare plasma dyscrasias besides multiple myeloma, but I will briefly talk about them because there are some orphan diseases. Unfortunately, in some countries, again, if there is not a well-established myeloma center, these patients or plasma cell dyscrasia centers, these patients are even lost before the diagnosis. That's why we need to be familiar with these entities also. One of them is AL amyloidosis. AL amyloidosis is characterized by the deposition of insoluble, aberrantly folded immunoglobulin light chains in tissues. Any organ can be involved, but the major three organs affected are kidney, heart, liver, GI tract, and nerves. And it's a rare plasma cell dyscrasia when compared with multiple myeloma. As you remember, the incidence of multiple myeloma was 5 over 100,000, but the incidence of AL amyloidosis is just 9 over a million population. It means you end up with 9 newly diagnosed AL amyloidosis patients per a million population in a year. And according to the deposition of amyloidogenic proteins, patients may develop renal failure, such as in multiple myeloma. But in this entity, this is mainly characterized by nephrotic range albuminuria. And also patients can develop heart failure, GI tract edema. These patients can present with a macroglossia or malabsorption. Because of this malabsorption, these patients can lose enormous amount of weight and can be cachectic. And also you can end up with hepatomegaly, severe peripheral neuropathy, and also bleeding. Like in this case, you have recognized, you have a bleeding on the orbital area. That's why we should think about a possible diagnosis of amyloidosis in patients who have non-diabetic nephrotic syndrome or hypertrophic non-ischemic cardiomyopathy, or patients who has an unexplained hepatomegaly or increased alkaline phosphatase without cirrhosis, or in patients who presents with demyelinating polyneuropathy with the presence of monoclonal protein, or in patients who are presenting with periorbital purpura or ecchymosis, or in patients who presents with macroglossia, it means the enlargement of the tongue, and also in patients who has an unexplained fatigue, edema, weight loss, or paresthesia. Then you should diagnose, you should be curious about an ongoing AL amyloidosis, and you should do your best in order to check for the presence of these amyloidogenic proteins via biopsying the affected tissue and organ and via showing the presence of amyloid protein by Tongoret stain on pathological samples. And also, you have a chance to document and identify properly the deposited protein with the help of a technique called mass spectrophotometry. And this mass spectrophotometry is just available on some expertise centers among these disorders. And also we have a rare entity also called as Waldenstrom Macroglobulinemia. And it's a clonal disorder of lymphoplasmacytoid cells producing IgM monoclonal protein. It's something like lymphoma, something like plasma cell dyscrasia. It's just at the middle of these entities. That's why we call this as a lymphoma-like plasma cell dyscrasia. And it's commonly associated with a generalized lymphadenopathy or organomegaly. And immunophenotypically, we can differentiate this from lymphoma and myeloma. And if you have this disease, you can end up with an overproduced IgM monoclonal protein, which causes hyperviscosity. And this hyperviscosity of the blood results with ocular disturbances, shortness of breath, or bleeding. That's why you should properly treat these patients in order to prevent these unwanted complications. And also we have some rare plasma cell dyscrasias, rarer than these, which are called as plasma cell leukemia or POEM syndrome. I will not get into details of these entities, but I can just say that our center is an experienced center among these even rarest plasma cell dyscrasias, and we offer our best to treat these patients who actually has a limited life expectancy. What about the treatment of myeloma and other plasma cell dyscrasias? You can just check this timeline. Up to 1970 and 1980, we were just trying to treat these patients with conventional chemotherapies like Melphalan or with the help of corticosteroids. But in this era, unfortunately, we were not actually treating this disorder. And we were losing all our patients in the second or third year of the diagnosis. But with the advent of some new drugs called thalidomide or bortezomib or lenalidomide or the others that I will mention in the next slide, we are now offering a wonderful life expectancy, which should not just be compared with this limited one. We can have our patients living beyond 7 and 10 years with the help of these drugs. And also, autologous stem cell transplantation had a great impact on this survival. That's why we offer autologous stem cell transplantation to all the patients who are diagnosed with multiple myeloma and eligible for this treatment. Because in autologous stem cell transplantation, we use a great amount of chemotherapy, and we just combine that chemotherapy with the stem cells which are collected from the patient itself. And why are we doing this? We are trying to even destroy any one cell which is abnormal. That's why we are using high-dose chemotherapy with stem cell rescue. And with the time period after this 1970, we are now managing to have patients living after this autologous stem cell transplantation via help of the modern anti-infectious drugs or some modern techniques. The mortality rate of this autologous stem cell transplantation is less than for over 1,000 patients. That's why nowadays we offer this treatment to all patients who can tolerate this high amount of chemotherapy and who can proceed with this procedure. That's why our center is applying around 50 to 70 autologous stem cell transplantations in 3 or 4 months in patients who are diagnosed with multiple myeloma. We are a real expertized transplantation center in this regard. As I have just mentioned before, the survival of multiple myeloma patients was very limited with only chemo approach before the invention of proteasome inhibitors like bortezomib and immunomodulatory agents like thalidomide or lenalidomide. But today, with the help of these novel agents and some new generation novel drugs, the median survival of myeloma patients has increased to 7 to 10 years. That's why we need properly diagnose these patients and we need properly treat these patients in order to achieve this great life expectancy. And also, as I told you before, high-dose chemotherapy with autologous stem cell support has an important role on this prolongation of survival. That's why any available patient should be treated with autologous stem cell transplantation after an induction therapy consisting the combination of these novel agents. Today, we just induce the patient with the combination of these proteasome inhibitors, immunomodulatory agents, and a short course of corticosteroids. With the help of this approach, we can suppress the plasma cells up to 90 or 100% in the end of this induction. And then we proceed with autologous stem cell transplantation in order to achieve a long period of progression-free survival. Unfortunately, myeloma can relapse, but we have great drugs to suppress these relapsing disease and to offer even a great life expectancy to patients even relapsing after this approach of induction therapy, autologous stem cell transplantation, and also maintenance therapy. Maintenance therapy with lenalidomide is paramountly important and should be offered to all patients. Unfortunately, we have some patients who are referred from some countries in which these drugs are not available. But these patients can have the opportunity to have these drugs from centers around the world like us. That's why I should just say that maintenance therapy with lenalidomide 10 milligram is as important as induction therapy and also autologous stem cell transplantation. This is the drug armamentarium of multiple myeloma. As you can see, we have wonderful, effective, and less toxic drugs nowadays to offer a great survival to our patients who are diagnosed with multiple myeloma. These are the commonly used ones, carfilzomib and pomalidomide, but we have a lot of ones, and also daratumumab is used commonly nowadays. But we have CAR T-cell therapies, antibody drug conjugates, and bispecific antibodies, which are really impacting the treatment of multiple myeloma and which have prolonged the survival of these patients. That's why these patients should be treated in expertise centers. And also, we can offer some clinical trials to our patients who has previously received these drugs, but unfortunately relapsed. In this scenario, the clinical trials is the best way to offer even newer therapies to these patients. And in my center, I am the chief of these clinical trials regarding multiple myeloma, lymphoma, and leukemias, and I have the opportunity to offer these clinical trials to our patients, even living in my country or the patients who are referred from other countries. That's why I'd be glad to be in contact with you regarding these novel therapies and also the clinical trials that you have. Unfortunately, you have unfortunately no therapy to offer to patients. We can have some clinical trials to offer some novel therapies to those patients who have lacked the response under these drugs. I will just stop here, and I'd be glad to be in close contact with you regarding your patients who are diagnosed with multiple myeloma or who are diagnosed with lymphomas or leukemias, any kind of hematological malignancies. I have my contact details, and I think the friends will just share those contact details with you. I'd be much more glad and appreciate to have your questions regarding these hematological malignancies, even the diagnosis of these diseases or the treatment of these disorders. Actually, also, I will be glad to have any kind of questions in a real time, maybe in an online meeting, which will occur after this meeting. I'd be glad to be in close contact with you regarding these disorders. Thank you. Have a great day. And also, I can just answer some important questions regarding these disorders. First of all, what is the incidence and what is the importance of multiple myeloma? I just really want to emphasize that again, that multiple myeloma is commonly seen in elderly patients and is the most common second hematological malignancy. If we do not properly treat this disorder, our patients should suffer from renal failure, even a chronic one, which needs a hemodialysis or a chronic renal replacement therapy. And also, our patients should suffer from bone fractures. Even these bone fractures can be lethal. That means we can lose our patients because of these unwanted bone fractures. That's why we need to properly diagnose and treat these patients. And another question is about the autologous stem cell transplantation. Should all patients proceed with autologous stem cell transplantation? For now, the short answer is yes. All patients who are diagnosed with multiple myeloma requires an autologous stem cell transplantation after a short period of induction therapy consisting some combination of novel drugs. Who has no serious cardiac issues, who has no serious pulmonary issues, and who are under 75 years of age, but also we can apply this autologous stem cell transplantation and high-dose chemotherapy to some patients who are in a good shape and in the age of 78. Actually, the age is not a limit. And another question regarding the novel agents, which should be the sequencing of these, and if we have no opportunity to offer these novel agents, what should we do? Actually, you should just refer those patients to expertise centers among these therapies and the centers which can even offer clinical trials of these novel agents to the patients. Actually, generally in countries around us, I know that you can have the opportunity to present or to treat your patients with bortezomib or cyclophosphamide or dexamethasone. But unfortunately, you lack lenalidomide, daratumumab, or pomalidomide, or carfilzomib, which are the drugs needed to offer a better overall survival to these patients. That's why we should be in close contact in order to check for the opportunities that we can offer to your patients. We should be in close contact. Thank you. That's all for now.